historic progress, but we don't have a cure yet. So there's still a lot of work to be done. And I think the future is bright.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, it's that time of year where I start thinking about all of these pediatric related kind of issues that come up. In dermatology, we're so lucky. We get to see the full plate of just the lifetime of anybody, like from little kiddos all the way to the geriatrics. But I've been thinking more about the kids lately. What do you think?
Yes, today we want to talk about a special medical condition called Epidermolysis Bullosa, which is a rare condition, a genetic condition, but really something that has become centerpiece in our dermatological care. These kids who now, many of them thankfully can turn into adults and maybe have a longer lifespan if they don't succumb to some of the cancers associated with some versions of the disease. Really, and their families are really burdened by this problem. And what is so cool is that now we're getting some new therapies, and we'll dive into this, but I cannot tell you how cool this is that EB really demonstrates how dermatology is really at the forefront of everything in science. Many therapies that have evolved for EB really came through this knowledge of the biology of the skin that we learned through these patients. So we're now coming finally full circle to be able to treat these patients. And it's really, really, really exciting time for epidermolysis bullosa. But as you can tell, a lot of times when it comes to genetic dermatoses, or what we call genodermatoses, I get a little nervous. I get a little timid. I think we all get a little flashback to our boards. And so, Raja, I think the two of us need an expert to guide us through this stuff.
Hadar, when we first started, we were in a lab that did a lot of cell biology with keratinocytes. And gosh, I remember we had a lot of conversations about EB research. So I'm pretty excited that we have an expert with us today. Let me start by saying that we are so lucky to get experts that do a lot of research, but Dr. Mercedes Gonzalez, she's a board certified pediatric dermatologist. So that means she's got special training in pediatrics within dermatology as well. And she's at Derm 360, and she's a medical director of pediatric skin research in Miami, Florida. So I just want to pause and say, gosh, we have a lot of folks that are clinicians. We get folks that are really good at investigations. Here we have a clinical investigator. So not only does she do stuff in the clinic, but she knows what's cutting edge. And she's an assistant professor of dermatology at Florida International University, at the Herbert Wertheim College of Medicine, and then also at the Philip Frost University of Miami Miller School of Medicine. So Mercedes, all that to say, we are so excited to have you with us on this podcast. And I also want to say that we are very thankful that this podcast is sponsored by Chiesi USA. So with that, we're excited to get our conversation started with you.
Thank you so much. It's such a pleasure to be here with you guys, Raja and Hadar. It's really a pleasure.
Hey, Mercedes, welcome to the program. This has been long awaiting on my part, at least, and really excited to have you here. I think I want to start actually by asking you what drew you to pediatric dermatology, because, it's a very unique kind of person that can handle kids and handle dermatology, but both together, it's really a cool people that I find that do pediatric derm. So what did you see in kids? I don't know. It's really sometimes very annoying. How can you handle this?
I think from very early on, right when I started medical school, I knew that I was going to work with children. So I really started, all of my focus and all my extra time and electives was doing pediatrics. And I really thought I was going to do a pediatrics residency, and I ended up doing one. But as I started learning a little bit more about it, I really felt that I needed to specialize. It was too overwhelming to know everything about general pediatrics. So I felt like I wanted to know a lot about one thing instead of a little bit about a lot of things. I knew I wanted to specialize. And so in my last year of medical school, I did several rotations in the pediatric subspecialties, and then I did a dermatology rotation. And that's when my eyes were open to the fact that I could see pediatric patients through dermatology. And I also really like the academic nature of dermatology and the procedural aspect of it. And so I thought I can do all these things and see my kids and treat the children. And so that's where I decided to go into pediatric dermatology. At that point, it was kind of late to start the dermatology application process. So I went ahead with my pediatrics residency, and I did that at Columbia University in New York. And then I applied to dermatology in the second year of my pediatric residency. And I did a dermatology residency after that, where, during both of those times, I did a lot of elective time in pediatric dermatology and just solidified my interest. And I had great mentors along the way. I had Dr. Maria Garzon, Julie Schaefer, Seth Orlow, Dr. Schachner were all great mentors to me. And then I completed a pediatric dermatology fellowship at NYU, as well as a clinical research fellowship in pediatric dermatology at the University of Miami, which is what kind of sparked my interest in clinical research, specifically within pediatric dermatology.
Yeah, I really wanted to ask you about this because we're going to talk a lot about some of the research that's done in EB, but how is doing clinical research in pediatrics different than what we are used to hearing about in adults?
And can I also jump in here and just say that it is so cool that you've started a research unit. So can you also talk about how your research unit may or may not differ from, say, like in a university setting? What's unique about yours as well?
Sure, I'll start with the first question. When you're working with children, it's much more challenging to get patients to be interested in participating in these clinical trials. They're not the ones coming forth; it's really the parents, and so really the trials that enroll best are the ones where there's large unmet needs. And the good thing about what's happening in dermatology right now is that we have an explosion of new therapeutics, and those new therapeutics are in disease states that primarily affect children. For example, atopic dermatitis, vitiligo, alopecia areata, and all of those new therapeutics, are lowering their age range to provide access to pediatric patients that are suffering from these severe skin diseases. And so, it's been really nice to be able to offer the option of a therapy where there's a big unmet need, in a disease state where there's a big unmet need. It's been awesome to have this center. And that's really how I started the center. I had a patient with moderate to severe atopic dermatitis back before dupilumab was approved. And I needed to get that patient dupilumab. I saw it was approved for adults. I knew it was there out there. And I met with the company who makes dupilumab, and I said, I need, how do I get my patient? Is there a site nearby? And they mentioned that they were going to be starting enrollment in a younger pediatric age group for the clinical trial, if I could be a site. And so I figured out a way to start a site or become a principal investigator in that trial. And I was able to be a principal investigator in the trial, working with another research center. And that's where I learned kind of all the ropes of how to start the center. And then a couple years later, I started my own center. Because of just, there was a lot of clinical trials coming in the pipeline that needed sites that could enroll pediatric patients in dermatology. And so I started my own private research site, and I called it Pediatric Skin Research, where I focus primarily on clinical trials that have pediatric age group enrollment, right? I don't take trials that are only adult trials. And the way they differ from academic institutions is that we're able to move a lot faster through the paperwork and through the IRB approval and through the contracting process. We don't have multiple layers of people who have to review contracts and change language. And then, the IRB, we're able to use a central IRB, where the turnaround time is less than a week for our IRB approvals. And we can do a lot of legwork as searching databases and reaching out to patients concurrently while we're doing the startup phase, so that when we're ready to start, we have patients ready to enroll. So it's really a quicker startup. That's the main difference. And I think accessibility to patients, I guess it's less intimidating to come to a private center than an academic center in some cases.
Yeah, and I think you're hitting right the spot that I think is really critical. That is accessibility and being able to reach with these clinical trials to the community where some of the patients may not be represented. So I think it's wonderful, and especially in the context of rare disease, where some of our uber experts, such as yourselves, are located in private practices. It's really helpful. And speaking of rare disease, I think we can now dive into to our main topic, because your story is very inspirational to a lot of listeners. So let's continue with that inspiration. And I think maybe just to get everybody on the same page, perhaps you can describe to us what is epidermolysis bullosa, that we for short call EB. And we're saying it's a rare disease, but how many people are really affected by this?
Sure. So EB, or epidermolysis bullosa, refers to kind of a group of inherited blistering disorders, and they're each caused by pathogenic variants in different structural genes, or genes that encode structural skin proteins. And so these are the proteins that are responsible for holding the epidermis to the dermis. So they're right at the dermo-epidermal junction. And the pathogenic variant leads to either decreased expression or completely absent protein, and depending on how severely affected, or depending on the pathogenic variant and what that results in, whether it results in a malfunctioning protein or completely absent protein, that translates into the clinical severity. So where you have malfunctioning protein, you have some protein there, the phenotype less severe in general. When it's completely absent, it's a more severe phenotype. And so far there's been about 16 genes identified where there are pathogenic variants that lead to the different clinical phenotypes of EB. There are 4 major types. The most common one is EB simplex. Then there's junctional EB, where your pathogenic variants are at the basement membrane zone. Then you have dystrophic EB, where the pathogenic variants affect collagen 7A1. So anybody who has dystrophic EB, they have a pathogenic variant collagen 7A1, and where you either make absent protein or minimal protein or abnormal protein there. And then Kindler EB, which is a much less common variant. Overall, fortunately, this is a very severe genodermatosis, but fortunately, it's very rare. Somewhere around 30,000 estimated people in the United States living with EB, and then global estimates around 500,000 people.
Got it. So something is gone wrong with the glue that sticks the skin together, and depending how up or down in that connective chain of proteins, wherever that defect is, we get a little less glue or completely absent glue, and boom, we get usually these kind of blisters and erosion, sometimes all the way to these chronic ulcers that kind of go and heal. It sounds tough, right? I mean, you talk to these patients a lot and their parents, and as they kind of grow up, and I'm sure some of these are like Ross and Friends. They keep coming back to their pediatric doctor, even as adults. So can you tell us about the journey these patients have to go through? It sounds pretty challenging.
Sure. So, for the more severe variants, like dystrophic EB, especially recessive dystrophic, or the junctional EB, this is something that becomes apparent at birth many times. So parents, are having, they're expecting their new child, they're there in the delivery room, and then day 1 or 2 of life, they start with blistering on their skin. And so all of a sudden, this super great moment of elation where you're, expecting a new baby, all of a sudden something's wrong. There's blisters, usually they're widespread on the legs or in the diaper area. And that's when you work up for the potential etiology. And, many times when you suspect EB, the first thing you want to do is send genetic testing. Really, that is the gold standard right now to make the diagnosis. And it does take a while. The turnaround is, especially, when you're in a hospital, it might be a little quicker, but you really want to send out for that genetic testing as soon as possible. Now that we have some FDA approved treatments, that genetic testing is much more important. So, the first thing is making that diagnosis, and then, the parents go through many stages of grieving and to acceptance. And then it's all about education about what the disease is and what the treatment options and what life is going to look like, depending on the diagnosis and then the predicted severity, right? So that genetic diagnosis is such an essential component of the counseling and what that family's life is going to look like in the future, right? So when you have the recessive dystrophic type, that's or the junctional type of EB. The wound care is very intensive. It can be sometimes 1 to 3 hours a day where you're doing dressing changes. The patients have to go see multiple specialists and can have recurrent infections. Chronic wounds can lead to problems with scarring, contractures over their joints. And then this chronic wounding also, rises your requirement for calories, and many times these patients are malnourished. They really struggle to keep up with the amount of calories they need for growth and for wound healing, and so that definitely contributes to the burden of wounds. And so they have a number of complications of chronic disease and growth delay as well.
Yeah, and I can say also from my personal experience for caring for some of these patients that really generously allowed me to kind of participate in their care, they become really good at taking care of themselves despite all these challenges. I mean, just for our listeners, imagine that every area of your skin that comes in contact or rubs against something starts breaking down in a blister. And then a wound or just a superficial erosion there that kind of sits there and takes days and days and days to heal. Really, really, really tough, as you can imagine. I mean, I like to tell people if just to understand, if you have one cut on your skin or one little wound that you have to deal with, just think about every day you wake up and go, oh yeah, I have this wound, I got to put a Band-Aid on it. Then you in the shower kind of falls and it's a mess, and then it's just one little Band-Aid. Now imagine multiply this by 10, 15 sometimes at a time, the wounds they have to care for. And you got to start getting a sense how this propagates, not to mention these kids who have to deal with school and, just growing up and being kids. And despite all this, and maybe you could speak to that, Mercedes, a little bit, the spirit that I see in these kids, I guess they just don't know anything else, but every time I see them, and I tend to see them more as adults, but the spirit, just the life that they project, because I don't know, I come out of that room elated. So, but you tell me, maybe to me it feels like they really are tough cookies. They kind of learn how to handle life pretty quickly.
Absolutely, and really, what impresses me many times is the parents. I always say the parent is the patient or the person with EB's physician. I'm just there for support. I'm really impressed with what these parents can handle and how they interact with their children, and giving them a normal life, as normal as possible. Because really, like you mentioned, such a tremendous psychosocial burden. Many times their patients, they suffer not being able to do the activities of daily living, going to school, and really the caregivers could very easily, become depressed or anxious. But I see the opposite. I see these caregivers really being champions for and advocating for their children, and it's really, really nice to see. Some of the best patient relationships I have are with these families.
Yeah, for sure. And I think now that we've kind of established this really significant unmet need and what these people have to go through, before we get to the innovations, because there, as you mentioned, there's some new therapies, but perhaps you can review with us what is the mainstay of care so far before we get these new treatments. Until about a couple of years ago, how did pediatric dermatologists and dermatologists in general manage these patients?
So really, prior to May of 23, when we had our first FDA approved treatment, the care was really supportive. It was focused on, number one, preventing trauma, right? Minimizing friction or any trauma on the skin to prevent that blistering from happening. And so these children were many times from day one of life wrapped in gauze bandages head to toe. And then when wounds did happen, the wound care routine would occur, where they were instructed to drain the blisters immediately and apply bland ointments, and then wrap them with the nonstick gauze, and the gauze wrap once again. And then it was surveillance for infection and complications. So the wounds can get infected. You know, in some subtypes of EB, there's a lot of excess granulation tissue that you have to manage, as well as surveillance for squamous cell carcinoma and other subtypes. And then the pain and itch management is so important. Too, many times the wounds continue to happen because of the constant itch and scratching that these patients suffer. And so we have better treatments for that now, but you know, we were just kind of going to our old traditional antihistamines in the past. And then of course, you know, optimizing everything else, you know, the other organ systems, nutrition, growth, and sometimes types of EB also have mucosal involvement. And so you really have to co-manage with other specialties, ophthalmology, gastroenterology, urology many times.
Got it. And so now let's really get to the fun part, right? So let's talk about some of the new treatments, because you kind of illustrated nicely what are our goals. We talked about educating the parents from early on, and then all the preventative care and everything. But now that we have these new therapies, I guess first maybe tell us what they are, what's currently available, at least in the U.S., to treat EB, and then we can dive into some of the nuances of the management.
The great news is that this is an area of active and significant research, and so it's really nice to see that, you know, that the future is bright for these patients and this disease. And just so we currently have 3 FDA approved EB specific treatments. The first one was approved in May of 2023.
Can I just say, holy cow? Can I just interrupt and say, holy cow? 3
Yes.
FDA approved for decades, nothing.
I know we had nothing for such a long time.
3, folks, are you listening? If you didn't fall off your seat, if you didn't veer off the road listening to this, if you didn't cut your finger while cooking in the kitchen, oh my God. Sorry, I just had to say, I mean, this is what I meant in the beginning. This is like unbelievable achievement for dermatology, for all the companies working so hard to develop this, and for the patients, because they have very strong advocacy group that's been working together with clinicians, with investigators, with companies, with everybody. So wow. Okay, go. Sorry, I had to just say OMG.
I agree, OMG. And if you look on the Deborah website for, you know, pipeline for, you know, enrolling active studies, it's also OMG. I remember, you know, when I was in my clinical research fellowship over 10 years ago, that page had one study on it because I was posting that study to help recruit patients for that one study I was doing back 13 years ago. Now I go to that same web page, there's like 20 or more different things enrolling.
Nice.
So it's definitely, you know, really exciting time. And in many ways, you mentioned this earlier, you know, could be considered a prototypical disease, since it's a single gene disease, right? And so if we can somehow figure out how to correct that gene, this can be translated into perhaps, right, other, you know, monogenic skin diseases, right? So it's great. Anyway, cool.
Anyways, I cut you off. So go ahead. So tell us the 3 FDA-approved treatments. Sorry, and thank you. We were stalling a little bit for that guy that veered off the road and had to come back.
Chronological order, I guess, you know, chronological order here. So May of 2023, our first FDA approval for Vyjuvek, which was a topical HSV-1 vector gene therapy for dystrophic EB. And so the way this one works is that it's a replication defective HSV-1 viral vector that contains 2 normal copies of the collagen 7A1 coding sequence. And this gets topically applied to the keratinocytes and fibroblasts, and it transduces them to produce their own normal collagen 7A1.
That is so cool. That's so cool. So you guys, you heard it here. This is like gene smearing is what we call it. You take the genes, you smear them on, and boy, they change the cells. It's pretty, I mean, it's just amazing. It's unbelievable, right? This is stuff that we dreamed of. Like, people were describing it in theory when I was in medical school, and it wasn't that long ago. I know some of you are looking at me funny, but no, it wasn't that long ago. And boy, okay, so gene smearing is number 1. Go ahead, yes.
Right, so this was applied weekly on wounds, right? And so, you know, patients are instructed to prioritize wounds because it's limited by volume. The weekly volume is limited. based on age of how much you can get. And so you prioritize the wounds that are most chronic and you want to close. And so you keep treating them weekly until they close, and then you go to the next wound. So this, this was something that got approved after the phase 3 pivotal trial with 31 wounds showing, significant efficacy versus placebo in the chronic wounds, and had really good safety profile. And also, these EB studies, now that there are more and more clinical trials for EB, they have validated measures for body surface area, for overall disease severity indices that have validated scores, as well as itch and pain scales, which we know are huge parts of the treatment. So I don't know about you, but for me, like in many disease states, when patients come back and they say that they're getting better, the thing that they're referring to is usually the itch and pain, right? They're not referring to wound size necessarily or easy score, body. They're really referring to that itch and pain that's not ruling their life, right? That's not impacting that quality of life. So I love that all of these studies with the new EB treatments included those itch and pain scales and showed significant improvement in both itch and pain with the use. So that was the Vyjuvik, and so next, December 2023, not too far after that, we got Filsuvez, which is also known as birch triterpenes. And this is a topical gel. So this is not a gene or a cell therapy. It actually is a gel that modulates the wound environment. So the mechanism of action is not exactly known, right? But there has many postulations. And so this is postulated proposed mechanisms of action. So, and this is something that is naturally derived. We know our patients love that, naturally derived from the bark of a birch tree. And it's been known for a long time that the components of birch bark have metabolically active properties, specifically in wound healing. The components are things like betulin, betulinic acid, luteol. These are all lipophilic molecules that insert into cell membranes and interact with multiple signaling pathways. So it is something that this extract from the birch tree is something that was initially seen to help with the healing of split thickness skin graft donor sites, as well as superficial partial thickness burns. And that was in Europe, where it led to an approval for that. Now, in the US, it was studied for EB, and it was studied as part of several clinical trials, and the largest one in EB that included over 250 patients with junctional and dystrophic EB. So it's approved for both junctional and dystrophic EB. In the clinical trial, patients were randomized into two parallel groups. Patients entered the trial and they either got the Filsuvez or vehicle, and they were observed for the primary endpoint of how many patients were able to have wound closure within 45 days. And what they saw was that the more patients that received the Filsuvez had complete closure within 45 days compared to the patients or the wounds that received the control gel. So 45 days, that's pretty quick. And to get into this trial, the wounds had to be open they were chronic, they had to be open for at least 21 days or less than 9 months. And they had to be of a certain size. The wound gel was applied with every dressing change. In addition, this study, the Filsuvez also looked at those overall disease burden, EB disease burden, the EB DASI, and the body surface area, and showed significant improvements compared to vehicle in those scales, as well as procedural pain and itch. So pain with the wound dressing changes was significantly greater than with the control gel, and improvements in itch similarly. In addition, one other thing that they looked at, which is huge for patients with EB, is the frequency of dressing changes. And what they saw is that the group that got the Filsuvez had fewer dressing changes, or required fewer dressing changes over the course of the study. And that, for me, is a very, very clinically impactful data point that I'm able to share with patients, and a reason that compels me to utilize this treatment for dystrophic and junctional EB patients.
Yeah, because I think it has a lot of implication to their daily life, right? The cost of treatment, the amount of time spent treating, right?
Absolutely. Some of these patients spend several hours a day, or each time they change their dressings, that it can be hours, 2 to 4 hours sometimes, doing a dressing change. I have one parent who has twins with dystrophic EB, and so multiply the
Oh boy.
dressing times two. So if she can reduce the frequency of that dressing change even by one less time per week, that is life changing for her. Life changing. And the Vilsuvis is something that has had several publications with real world use as well. There are several publications out there showing real world use where that is corroborated, where patients are reporting less frequent dressing changes, and that is so important for these families, giving them that time back, a little bit of normalcy back, right? We don't get out of the
Right.
shower and have to put 1,000 bandages on, right? So giving them
Right.
a little bit of that back.
And so just to catch myself up, so we had so far two treatment. One is the gene smearing, all right, that we give a specific gene, and that's really collagen 7, so that's for really one type. Where here we have a more general, supportive, kind of natural, and you can kind of make sense, right? Because our natural therapies usually,
Naturally derived as well, right? In a way, I mean, there's
yes,
bird
Right,
exactly.
terpenes, right?
right.
So those are usually more kind of broad spectrum and kind of modulate the whole environment, which is
Yeah.
really cool because that makes them also, correct me if I'm wrong, but also FDA approved for two indications, right? So they have both dystrophic and junctional EB, right?
Exactly. Yeah, and the application is different, right? So this is, it's that naturally derived it helps with wound healing by promoting that keratinocyte revitalization, as well as dampening that chronic inflammation. And so it's meant to be used with each dressing change. You can apply a thin layer either directly on the wound, about 1 millimeter thick. So this is more of a smearing, I would say, than the other, where it's like droplets, and then this is true one
Yes.
millimeter thick smearing either on the wound bed, or you can do that on the wound dressing and then place the wound dressing on the wound. And you would do it with each dressing change.
Yes, which is usually a lot easier than kind of, yep. Sorry. Okay, so now what else we got?
Now we got just this year, April 2025, something called Zevaskin. And this, the generic PZ cell is what it was known before the approval, and it got its fancy name of Zevaskin. This is an ex vivo cell based gene therapy, and this is for recessive dystrophic EB. It is autologous, so that means it's their patient's own skin that then gets gene corrected and made into keratinocyte sheets. So the way this one works is that patients give two 8 millimeter punch biopsies are taken and sent to a lab where keratinocytes are isolated. Then there is a retroviral vector that has the collagen 7A, the full length functional collagen 7A1 gene that is transduced into the keratinocytes. Then the keratinocytes are made into epidermal grafts. And the total grafts that you can get from two 8 millimeter punch biopsies is about 12 sheets that are around 40 centimeters squared each. Okay, so that whole process takes about 25 days from the time that biopsy is taken, sent to the lab, it's transduced with a retroviral vector, and then the sheets are ready to be sent back. That whole process roughly around 25 days. Then the grafts get sent back, and it gets applied to the patient. Prior to application on the wound, there has to be debridement and preparation of that wound. The sheet is then sutured to the wound bed after the debridement, and then it's covered with the patient's standard kind of dressings. The important part of this, is a key part of this whole process, is after that graft is sewn on, there has to be minimal disruption or movement around that wound for about 5 to 7 days. So immobilization, basically, of the wound that is grafted, and then that really correlates with success and the take of that graft. And then after that, it's ongoing standard wound care. But this one again was studied in phase 3 pivotal trial where the primary endpoint for this one was a little bit different. Here they looked at 50% wound closure at 6 months. And it was an intrapatient control where they had one wound receiving standard of care, and then one wound had the Zevaskin graft applied. And so they saw that 81% of the Zevaskin treated versus 16% of the control wounds had more than 50% wound closure at 6 months. And they also looked at the pain improvement, and it was significantly greater with the Zevaskin treated wounds. So here more of a process. And this is really meant for larger more chronic wounds. In the study, the wounds had to be at least 20 centimeters squared or greater. And so this is something you have to plan out, and it's only done at certain specialty centers.
Yeah, and so just a mechanism here, instead of taking the gene and through a virus specifically directly applied to the wound, here we take the patient's own keratinocytes. We give the same gene, but we actually deliver it with the patient's own cells, right? So that's the difference.
Yeah, using the smear analogy, I guess it's like they're making a bread with the gene in it, and returning a piece of bread.
I love it.
With the bits of cream cheese put in there.
Throw it in there, make a roll out of it. Okay, gotcha.
On the wound. You're actually getting something back to place on the wound, and it's sewn at the sides.
Yeah, and just to highlight this, just to give people a sense of about 40 centimeter, that's an area of an average credit card. And so they can do, I think, up to 12 treatments, right? Up to 12 sheets. So that's like 12 credit cards, right?
About 12 credit cards, exactly. Yep. Yeah.
Yeah. So and you need a biopsy for each one of those?
No. So biopsies you take from a normal skin. You take from the patient. You take it from the patient.
Right.
But non-wounded area.
But one biopsy is enough for all these what we call 12 credit cards for the almost
the two 8 millimeter biopsies. 2 8 millimeter biopsies.
Yeah. 2 8 millimeters. So that's that's a process, and could be also somewhat traumatic for kids, I suppose. But hey, this is unbelievable. Just the notion of this like 10 years ago would have been crazy. So that's unbelievable. Well, good. Now, what I wanted to talk to you as being part of some of these studies, if not all these studies, what has been your experience so far with these products?
So far, it's been excellent to have options to offer patients, something actually that's prescription, that's specifically studied and meant for and indicated for their disease state. And we have seen tremendous results. Currently on label, many of these don't specify using them together. But really, in reality, given the limited number of approved treatments or real treatments directed, at the underlying etiology, patients want everything that they can get. And so a lot of our patients, with recessive dystrophic EB do use both FDA approved products. I have not had any patient yet undergo the process of Zevaskin. That is a more, you have to plan that one out. There's only 3 centers in the US currently doing that, and so you have to schedule that in advance. But all of my patients, with dystrophic EB are on both of these topical treatments.
Yeah, and it's pretty incredible. So I think I heard it from you, but just to put you on the spot, because that's the question I hate the most, Beth. So I'll put you right on the spot there. So how do you decide who's going to get what? I think I heard you maybe allude to it, but how do you decide?
Vyjuvik was around. First, I started, and I did the clinical trial for that one. So they, many of my patients were in the trial, and so they continued on after the trial using it weekly, and you prioritize wounds there, right? So once the wound closes, you move to using it in another spot. And then the filsuvas, when filsuvas came, we added that in to the other wounds. So the wounds that were not having the Vyjuvik placed, they were using those every day. And then we started, this is off label, perhaps is using the filsuvas to the wounds that were getting Vyjuvik weekly on the dressing changes where Vyjuvik wasn't applied. So they wouldn't be applied at the same time, right? But they are applied to the wound on the days that the Vyjuvik is not being applied.
Got it. And maybe briefly, you can tell us, how do you coach parents on these? Because I think it's important for how do you go through the process of explaining this? Perhaps, not everybody treats EB, but for the dermatologist who's listening and want to refer a patient, how do you coach parents? What do they need to know?
Let me tell you, the majority of the time, the parents are telling me what works best because they all have
That's
their
true.
own way
That
of
is
doing
true.
and cutting the dressings and things like that. But the advantage of the first treatment, the Vyjuvik, I was able to utilize that early on, and I knew how to apply it. I was applying it myself, and so anytime I'm applying it, the parents watching me. So I kind of would show them how that was applied, and then how it needed that hydrophobic dressing right on there afterwards, and then the wound dressing right after. The same with filsuvas, kind of demonstrating how to put it on either the wound dressing or on the wound bed. And each parent kind of has their own preference, right? Depending on the child's sensitivities and things like that. So it's just really demonstrating it and then listening to them, what works best for them, and incorporating it into their routine. And I will say overall, what I've seen in a lot of my adolescents is less bandages. So not frequency, because I'm not really keeping track and of that at each visit, but the bandages overall. These were kids that were kind of wrapped from finger to shoulder, right, with a gauze. And now I see like they're leaving like little openings of their forearms. So they're less. They're not a full mummy, but they have exposed areas, and that really helps them with movement and just feeling a little bit more free.
Well, Mercedes, this was such an excellent conversation, just taking us through all of what's really coming out as new innovations. And of course, this is such a challenging set of conditions. So maybe to kind of get to an overall take, because you've been in this field for quite some time and dealing with the challenges that come with these set of conditions. If you were given one wish for EBE, what would it be and why?
Oh man, that's for me. It's a cure. We don't yet have a cure, and that cure should be kind of this. Since it is, like I mentioned, this single gene, that should be a gene or cell based cure that can be given really early in life. Ideally, we could identify these pre or perinatally, and we can correct that gene then to really help prevent the blistering and prevent the sequelae that these blistering diseases can have. I mean, you want to catch it early and fix it early. That would be the ultimate goal, and I do think that's possible one day.
Yeah, I mean, I have to say, I mean, the amount of progress we've made is staggering. So I echo Hadar's enthusiasm for this. And then, what are your final takeaways for everyone about what they should know when it comes to EB? And what do you think has been special for you being a pediatric dermatologist as opposed to, say, a general dermatologist? Any differences there in terms of, how you've been able to address these sort of issues?
I think as having some pediatric experience, I think that I just naturally incorporate the family in a lot of decision making processes, and I'm used to working with multiple specialists, having that background, and that's something that's very important for patients with EB, that multidisciplinary care, making sure that they're being appropriately watched for complications, and the complications are being managed. Overall, this is a devastating disease, and it's something that for the first time now patients are given some hope with these 3 FDA approved EB specific therapies, the filsuvas, Vyjuvik, and Zevaskin. This is like historic progress, but we don't have a cure yet, so there's still a lot of work to be done. And I think the future is bright, and it's important. The other great thing about EB, last thing, is that the patient organizations here are so great, and this community is so strong. And that's another reason why I think the future is bright, because with the interest in the research from the pharmaceutical companies, plus the patient enthusiasm and the togetherness of that community, I think that's going to be helpful to make the future even better for these patients.
Well, Mercedes,
folks.
Yep, I was just going to say that, Hadar. This was such an awesome episode. I mean, I've learned more about EB than I've learned through probably the last 10 years just sitting here. This has been amazing. And just to look at how the innovations have been coming forth, not just in gene therapies, but looking at naturally derived, I mean, talk about an integrative approach to just, treatments, let alone just integrative approach to care. And overall, I just want to say thank you so much for all of your expertise today. And then Hadar, I think you were about to say something too, but I just wanted to just express how much.
Yeah, no, I just wanted to echo again my enthusiasm. And for those of you who are listening, if you know of a clinician who knows someone with EB, because like we mentioned, it's a rare disease, if they don't already know, because as was mentioned here, a very strong community, but if they don't already know, send them to a dermatologist who can help them, perhaps a pediatric dermatologist. Even if it's an adult, a lot of times the pediderms are really well connected and can guide them into the right direction. And in some advanced wound centers, also these therapies are available. And really, it's kind of a new era for people with AB. So we all need to be aware of this. We all need to direct patients to the right doctors that can give them the right care. And those are usually board certified dermatologists. So with that, Mercedes, thank you so much for your expertise, for your hard work on this. It's really, really inspiring, both from your personal career standpoint, but also from the advancement in this field. And I hope to see you soon on an episode. Bye.
Thank you so much. This was so fun.
And that wraps up today's episode. But as always, it feels like we've only scratched the surface, dude.
And that's exactly why we've created the Integrative Dermatology Certificate Program. We've been doing this for several years, and it keeps getting better and better. And the IDCP is designed for board-certified dermatologists who want to incorporate integrative strategies in a rigorous, evidence-based way.
From complex inflammatory skin conditions to real-world case applications, this highly rated program is focused on practical tools you can bring straight back into clinical practice tomorrow.
So if you're looking to deepen your clinical approach and stay at the forefront of integrative dermatology, you can learn more about the IDCP at learnskin.com.
So, what are you waiting for? Go to learnskin.com and join IDCP today.